ESO, including founding the Guideline group. So we look forward to hearing the intracerebral hemorrhage guidelines. Now, this is a guideline that is not yet complete and ready for publication, but it's on its way. Torsten, over to you.
Thank you very much, Terry, Diana. Thanks for speaking. These 6 trials, or I should say the 5 of these trials have been published until today, within the last 4.5 weeks. And tomorrow we will hear about another randomized controlled trial. We had not in all of these the chance to get data before. These are the 6 areas we have picked for the guideline. So they are general management, blood pressure lowering, hemostatic therapy, surgical intervention, prevention of complication, and secondary prevention. And the 6 trials you have seen there will have a major impact on the ICH guideline. And because of that, it was decided not only by our working group, but together with the guideline board and the executive committee, that we will not present final and reviewed recommendations today. But what I will do instead, I will tell you a little bit about how these trials might have an influence on the recommendations within the next minutes. I start with general management, and the other question I would like to, or the other problem or aspect I'd like to discuss with you is, we have discovered that there are many overlapping aspects and problems, not only in the ICH guideline, but with other guidelines. And the question is, how do we deal in the future with this? And I'll give you a few examples of how we dealt with that. And the first example is the PICO question on outcome prediction tools. Here, thanks to Terry and Rachel Garthy, we have a Cochrane review, which is not published yet, but we have the chance to integrate this into the guidelines. And what you can see here, there was a total of 97 prediction tools. And when we went through the points of external evaluation and assessments, finally we found that there are only 2 of these prediction tools that have an external validation of, or more than 2 external validations, and have actually very good ROC values. This leads me to the area of blood pressure. This morning we have heard about the INTERACT-4 trial. The INTERACT-4 trial is a trial on acute lowering of blood pressure in patients with acute stroke, no matter whether they have an ischemic stroke or an intracerebral hemorrhage. And what was compared was an intensive blood pressure lowering with usual care. Usual care, according to Chinese guidelines, is to keep the pressure below 140 millimeters of mercury. The primary endpoint was the modified ranking score, and you have heard the results this morning. For us, it is important to see that 43% in each of the groups had an hemorrhagic stroke or intracerebral hemorrhage. 85% of these hemorrhages were located in deep location, and in terms of generalizability, something we will certainly have to discuss, is that all of the patients come from China. What we, Craig Anderson kindly enough agreed to that he gave us data before the publication, and this enables me to show you a little bit of how INTERACT-4 had impacted the results. So this is mortality at 3 months and 3 to 6 months. And what you can see on the right side is the meta-analysis of 13 trials without INTERACT. On the left side, you see the impact of INTERACT-4. And you see that here is it favors vasodepressors, and you see that this has an effect towards a benefit by the adding of the INTERACT-4 trial. This is a good functional outcome, modified ranking score on the right side without, on the left side with INTERACT-4, and again you see a shift towards better outcomes through the adding of the INTERACT-4 trial. Finally, we all want to know what is the pathophysiology behind this. We all think that hematoma expansion reduction leads to an improvement of clinical outcome, and maybe this is another hint towards the proof of this hypothesis. As you can see on the left side, adding INTERACT-4 to this concept, thus making it a shift towards lower hematoma expansion or reduced risk of hematoma expansion. This leads me to the next area, which is the area of hemostatic therapies. And as you can see, we divided this section into spontaneous and into ICH that is associated with anticoagulants. We have heard about these results from the Annexa I trial, but we were all waiting for the publication, which took place during last night. Just to repeat that, this was a comparison of andexanet alpha versus standard therapy. Inclusion criteria were patients with an ICH imaging proved last intake within 15 hours and a volume up to 60 milliliters. I think these are the most important things to be regarded. The primary endpoint was a combined endpoint called effective hemostasis, which was a combination of hematoma expansion, increase of NIH stroke on the NIH stroke scale, and the use or not use of rescue therapy within 3 to 12 hours. I would like to point out a few things which might become or will become important when we will decide about the risk and benefits of this treatment. And this is relating to atrial fibrillation. As you can see, there is more atrial fibrillation in the andexanet group. It's interesting to see that most of the patients still received apixaban and rivaroxaban. 10% did receive edoxaban. Hematoma volume in the range of median 9.8 milliliters, 10.5 in the andexanet alpha group, and usual care 9.3 milliliters. We need to analyze how this might have impacted on outcome, because we know it is actually very small differences in volume that have an impact on clinical outcome. The other interesting observation, I think, is the time until the treatment, which is, given daily practice, relatively long. Of course, it is explainable because there is a randomization procedure in between. However, if you think of the concept of early hematoma expansion, we may ask ourselves, what might these results have looked like had we have treated the patients earlier with a hemostatic agent? This is a screenshot from the publication that came out last night, and as you can see, nothing new here. We have a positive effect of the treatment on this combined endpoint, which is mainly driven by the change of hematoma volume, not by the clinical endpoint of NIH stroke scale. And the other thing is, and this is why I refer to risk-benefit balance, is the fact of thromboembolic or thrombotic side effects. And as we have heard already in Toronto, there is an increased signal for patients who did suffer from a stroke, which is 6.5% in the andexanet alpha group and 1.5% in the usual care group. Questions we will have to answer is how do we evaluate the risk-benefit analysis? I would like to point out the very interesting talk we heard this morning from David Seifke, who told us that there is an analysis already, and we will certainly take this into account. Furthermore, you have seen that many patients, 87% of the patients, did receive prothrombin complex. Only 13% did not receive prothrombin complex in the usual care group. And it would be interesting to see how the results look like if we have a direct comparison between andexanet alpha and the PCC group in terms of clinical endpoints and in terms of different dosages. I spoke a little bit about baseline volumes and those differences, and I spoke already about the time until treatment. This leads me to the next area, which is the area of surgical interventions, and you can see that we divided that into 3 sub-areas: supratentorial, interventricular, and infratentorial ICH, and then we have different subgroups there depending on different techniques. One of these is minimally invasive surgery, and the other new one is decompressive surgery. Certainly I'm alluding to this because we have these 2 new trials, Enrich and Switch. Enrich we heard about last year. So just to repeat that, it is a minimally invasive procedure which is using a device applied parafascicularly to the brain, and that is thought to be one of the conceptual pros of this approach, and this was compared to best medical therapy. The utility-weighted modified ranking score was the endpoint. Remember that the volumes we have seen here are definitely higher than we know these volumes from trials I have spoken about and we have heard about today. Here we are dealing with larger hematomas in the range of 55 milliliters. As you may recall, the trial sensed that there is no signal in deep hemorrhages, but there is a signal in lobar hemorrhages, and that is why nearly 70% of the patients had in this analysis were lobar hemorrhages. The time until treatment was 16 hours, and what we got to know is that this is a positive trial when we look at the lobar hemorrhages. And this went into one of the our meta-analysis when it comes to functional outcome according to different types of minimally invasive surgery. You find the Enrich publication in the area of tubular access versus conservative treatment, and you see that this favors treatment with the minimally invasive surgery, but you see that all the other methods are showing a similar or going in a similar direction. So if you ask me for a preliminary conclusion, we may say minimally invasive surgery might reduce mortality. Basal ganglia hemorrhages were excluded in hemorrhage. I think that is a very important thing. And we certainly need to further analyze the different technical approaches and the timings. And the recommendations or the recommendations on deep hematomas is still will be still uncertain, because I don't see, at least for these techniques, that we have randomized controlled trials we can base our analysis on. This leads me to decompressive surgery. We heard about the Switch trial yesterday. Switch compared decompressive surgery with plus best medical treatment with best medical treatment. Endpoint was the modified ranking score at 180 days. Inclusion criteria were patients with a supratentorial deep ICH, Glasgow Coma score 8 to 13, 10 to 30 points on the NIH stroke scale, and randomization to surgery within 6 hours. Volumes, again, high volumes between 30 and 100 milliliters. The result on the primary endpoint was just missed significance, but the secondary analysis of the endpoint, which was pre-specified, revealed a significant impact, positive impact of decompressive surgery in these patients. We put this into a meta-analysis for the endpoint of modified ranking score 0 to 4, and you see that this is in benefit of the treatment. I would like to point out that we have 2 other PICO areas. The one area is the area of prevention of complications. So far, guidelines have regarded each of these aspects you see from 1.1 DVT up to 7 seizures, dealt with each of these aspects. But now we have trials on care bundle, and so in addition to what we did for the last guideline, presenting recommendations on each of these single aspects, we will now have a second sub-area that will deal with a PICO question on care bundles. And there are 2 randomized controlled trials, the INTERACT 3 and the QUASC trial, which we put in the analysis, and we certainly will also analyze data from the ABC trial from Adrian Parent-Jones from 2019. Finally, the last PICO question or sub-area of PICO questions is dealing with secondary prevention, aspects like blood pressure, anticoagulation, left atrial appendix occlusion, antiplatelet therapy, and the use of statins. My preliminary conclusion is we have the pleasure to be in a time where we see more and more evidence from randomized controlled trials. Imagine how the situation looked like 5 to 10 years ago. And now I'm standing here in front of you, excusing myself, not presenting recommendations because we have so many randomized controlled trials coming up within the last 4.5 weeks. The other thing I think we can conclude already is we have to realize that ICH, acute ICH, is an acute disease, and the prognosis is highly dependent on that we act fast. I think that's the main message from these trials. The perspective is that I would like to mention one thing else, and this is ESO has agreed on recognizing the importance of ICH, and therefore since last year we have an ICH committee and the duty of that ICH committee is promoting research in ICH. Perspective, you'll definitely see, and I forgot to mention this, the ESO guideline, which is done together with the European Association of Neurological Societies within the next weeks. Thank you very much.
Fantastic, thank you, and we look forward to seeing the final document. Officially, we're over time. We could probably squeeze in just one question if there's one burning question. Otherwise, Torsten is here. I'm not seeing any questions, so it just remains for Diana and I to thank you and enjoy the rest of the conference. Thank you very much.
half the contact can be 24/7.
De novo, né? Sim, que agora que eu realizei.
Они маме, детям, они
Останні.